I've declined 5 surgical procedures over the past 2 decades that colleagues insisted were necessary. Each time, I implemented evidence-based alternatives instead. My biological age, measured through DNA methylation analysis, now tests 8.4 years younger than my chronological age. My cardiovascular markers, inflammatory profiles, and metabolic function have all improved consistently, without a single surgical intervention. I'm David Sinclair, professor of genetics at Harvard Medical School, where I've spent 25 years studying why we age and how to reverse that process. Today, I'm sharing the 5 surgeries I would refuse and the precise protocols I would implement instead. Let me be clear about something before we begin. This is not medical advice. These are my personal decisions based on my understanding of the research. Your situation may differ, and you should always consult with qualified healthcare providers. But I believe you deserve to understand what the science actually shows before making irreversible decisions about your body. The first surgery I would refuse is coronary artery bypass grafting, commonly called CABG or CABG, for stable coronary artery disease. Let me be absolutely clear about one thing. If you're having a heart attack or experiencing unstable angina with rest pain, emergency intervention saves lives. I'm not discussing that scenario. I'm discussing the far more common situation, stable chest pain with exertion, where a cardiologist recommends bypass surgery to prevent a future heart attack. Here's what most patients never hear. The COURAGE trial, published in the New England Journal of Medicine, followed over 2,200 patients with stable coronary artery disease for nearly 5 years. Half received optimal medical therapy alone. Half received medical therapy plus coronary intervention. No difference in death rates. No difference in heart attack rates. The invasive procedure provided no survival benefit over medication and lifestyle modification. The ischemia trial, published in 2020, confirmed these findings in an even larger population, over 5,000 patients. After more than 3 years of follow-up, no significant difference in death or heart attack between invasive and conservative strategies. So what's happening at the molecular level that makes this possible? Atherosclerotic plaques aren't simply mechanical blockages like a clogged pipe. They're dynamic inflammatory lesions. The plaques that rupture and cause heart attacks are typically not the ones causing the most narrowing. They're inflamed, unstable plaques with thin fibrous caps, often in locations with only moderate stenosis. Bypass surgery routes blood around a blockage. It does nothing to stabilize the hundreds of smaller plaques throughout your coronary tree. It does nothing to address the underlying inflammatory environment driving plaque progression. What does address inflammation? What stabilizes plaques? What actually reduces cardiovascular events? Here's my protocol for cardiovascular optimization. First, I maintain a time-restricted eating window of 18 to 20 hours of fasting daily. Fasting activates AMPK, which functions as a cellular energy sensor. When AMPK activates, it suppresses NF-kappa B, the master inflammatory transcription factor. Studies demonstrate that intermittent fasting reduces circulating inflammatory cytokines by 20 to 40% within weeks. Second, I consume 2 to 4 grams of omega-3 fatty acids daily from wild-caught fish and supplemental EPA and DHA. The Reduce It trial showed that high-dose EPA reduced major cardiovascular events by 25% in high-risk patients, a larger effect than bypass surgery provides for stable disease. Third, I eliminated seed oils entirely from my diet approximately 15 years ago. Linoleic acid, the primary fatty acid in soybean, corn, and canola oils, serves as the substrate for pro-inflammatory prostaglandins and leukotrienes. Fourth, I walk for 10 to 15 minutes after every meal. Post-meal glucose spikes generate advanced glycation end products that damage the arterial lining. Walking reduces these spikes by 30 to 50%. Fifth, I take 500 milligrams of quercetin daily. Quercetin inhibits foam cell formation, the lipid-laden cells that constitute the core of atherosclerotic plaques. My most recent coronary artery calcium score was 0. My C-reactive protein measures 0.3 milligrams per liter, well within the lowest risk category. These markers indicate that my protocol is addressing the underlying disease process, not merely routing blood around it while leaving inflammation unchecked. Surgery number 2, spinal fusion, 5 minutes to 8:15. The second surgery I would refuse is spinal fusion for degenerative disc disease without neurological deficit. Spinal fusion has become one of the most commonly performed orthopedic procedures in the United States. The number of lumbar fusions increased by over 170% between 1998 and 2008. Yet the evidence supporting its use for simple degenerative disc disease is remarkably weak. The Swedish lumbar spine study compared fusion surgery to structured physical therapy for chronic low back pain. At 2 years, surgical patients reported slightly better outcomes, but by 4 years, those differences had vanished entirely. More concerning, fusion patients had a 17% rate of significant complications, including infection, nerve damage, and adjacent segment disease. Adjacent segment disease deserves particular attention. When you fuse 2 vertebrae together, you eliminate motion at that segment. The body compensates by increasing motion at adjacent levels. Research shows that adjacent segment disease requiring additional surgery occurs in approximately 3% of patients per year. Over a decade, nearly 1/3 of fusion patients require reoperation. The fundamental problem with fusion for degenerative disease is conceptual. Disc degeneration is ubiquitous. MRI studies of asymptomatic individuals show disc abnormalities in 37% of 20-year-olds and 96% of 80-year-olds. Finding a degenerative disc in someone with back pain does not mean the disc is causing the pain. What actually causes chronic low back pain in most cases? Central sensitization, myofascial dysfunction, deconditioning of the stabilizing musculature, psychological factors including catastrophization and fear avoidance. None of these respond to fusion. Here's my protocol for spinal health. I perform resistance training focused on posterior chain development 3 times weekly. The deep paraspinal muscles that provide segmental stabilization atrophy rapidly after back pain episodes. Specific retraining reduces recurrence of low back pain by over 50% at 3-year follow-up. I maintain a daily walking habit of 8,000 to 10,000 steps. Walking provides gentle cyclic loading that nourishes the intervertebral discs through a process called imbibition, compression and decompression that pumps fluid and nutrients into the avascular disc. I take hydrolyzed collagen peptides daily. Type 2 collagen comprises the majority of the disc's inner structure. Studies show collagen supplementation increases proteoglycan synthesis and may slow degenerative changes. I prioritize 90 minutes of deep sleep nightly. Growth hormone, which peaks during slow-wave sleep, is essential for disc repair. Sleep deprivation reduces growth hormone secretion by up to 70%. I manage cortisol through morning sunlight exposure and evening relaxation practices. Chronic cortisol elevation accelerates disc degeneration through enzymes that degrade collagen. My current status at 55, full range of spinal motion, no limitations in activity, and I regularly deadlift twice my body weight. Every one of my colleagues who underwent fusion in their 40s now has less function than they did before surgery. Surgery number 3, knee replacement, 8:15 to 11 o'clock. The third surgery I would refuse is total knee replacement for early to moderate osteoarthritis. Knee replacement surgery has become remarkably common, over 700,000 procedures annually in the United States. For severe, end-stage arthritis in appropriate candidates, it can be transformative. I'm not discussing those cases. I'm discussing the growing trend of performing knee replacement earlier and earlier in the disease process, often in patients in their 50s or even 40s with moderate arthritis who still have reasonable function. Here's the problem. Knee implants don't last forever. Modern prostheses have a 15 to 20-year survivorship of approximately 85 to 90%. That sounds acceptable until you consider what revision surgery entails. Revision total knee replacement has significantly higher complication rates, poorer functional outcomes, and shorter prosthesis survival than primary replacement. If you undergo knee replacement at 50 and live to 85, you're facing at least one revision, possibly two. The Meteor trial compared arthroscopic partial meniscectomy to physical therapy alone for degenerative meniscal tears with osteoarthritis. At 1 year, no difference in outcomes. The surgery provided no benefit over exercise. What does help moderate osteoarthritis? Exercise has the strongest evidence base of any intervention. A Cochrane review of 54 trials found that exercise reduces pain and improves function comparably to anti-inflammatory drugs, without the cardiovascular and gastrointestinal risks. Here's my protocol for joint health. I perform low-impact resistance training that loads the joint through full range of motion. Cartilage is avascular. It receives nutrition through synovial fluid, which is pumped through the tissue during compression and decompression. Appropriate loading actually stimulates the cells that maintain cartilage. I maintain body weight at a BMI below 24. Each pound of body weight translates to roughly 4 pounds of compressive force across the knee during walking. Losing 10 pounds reduces knee loading by 40 pounds with every step. I take 500 milligrams of curcumin in highly bioavailable form twice daily. Curcumin reduces production of inflammatory cytokines that accelerate cartilage breakdown. A meta-analysis concluded that curcumin provides pain relief comparable to ibuprofen without the gastrointestinal side effects. I consume bone broth as a source of glycine, proline, and hydroxyproline, amino acids that serve as building blocks for collagen synthesis. I supplement with glucosamine and chondroitin daily. The largest meta-analysis found that pharmaceutical-grade glucosamine chondroitin reduces joint space narrowing over 2 to 3 years. My knees, at 55, have no pain with any activity. I ski, hike, and perform full-depth squats regularly. The orthopedist I consulted 5 years ago recommended I start thinking about replacement within the next decade based on some mild joint space narrowing on X-ray. I declined. The narrowing has not progressed. Surgery number 4, thyroidectomy, 1100 to 1315. The fourth surgery I would refuse is total thyroidectomy for small, low-risk papillary thyroid nodules. Thyroid cancer incidence has tripled over the past 3 decades. Yet, thyroid cancer mortality has remained essentially unchanged. What explains this paradox? We're not seeing more aggressive thyroid cancer. We're detecting more incidental thyroid nodules through imaging performed for other reasons: CT scans, MRIs, carotid ultrasounds. We then biopsy these nodules and find cancer. Here's the critical point. Autopsy studies reveal that 10 to 36% of people who die from completely unrelated causes harbor occult papillary thyroid carcinoma. These cancers never cause symptoms, never spread, never would have affected lifespan. They're what researchers call overdiagnosed disease, cancer that exists but doesn't matter clinically. Small papillary thyroid cancers under 1 centimeter without aggressive features have a 20-year disease-specific survival rate exceeding 99%, regardless of treatment approach. A landmark study from Japan followed over 2,000 patients with small papillary thyroid cancers under active surveillance, rather than immediate surgery. After 10 years, only 8% had grown significantly. Only 3.8% had lymph node involvement. 0 patients died of thyroid cancer. Meanwhile, thyroidectomy carries real risks. Permanent damage to the parathyroid glands occurs in 1 to 2% of cases, requiring lifelong supplementation. permanent nerve injury causing voice changes occurs in 1 to 2%, and all patients require lifelong thyroid hormone replacement. Here's my approach to thyroid health. I optimize iodine status through regular consumption of seafood and occasional seaweed. The thyroid requires iodine for hormone synthesis, and both deficiency and excess can contribute to nodule formation. I support thyroid hormone conversion through selenium supplementation. Selenium is essential for the enzymes that convert inactive T4 to active T3. I minimize exposure to thyroid-disrupting compounds. Certain chemicals interfere with thyroid hormone production and receptor binding. I filter my water, avoid plastic food containers, and minimize processed food consumption. I maintain low systemic inflammation through the dietary and lifestyle practices I described. Chronic inflammation drives cellular proliferation and may contribute to nodule development. If I developed a small papillary thyroid nodule, I would opt for active surveillance with serial ultrasound rather than immediate surgery. The Japanese data provide compelling evidence that watchful waiting is safe for low-risk lesions. Surgery number 5, carotid endarterectomy, 1315 to 1530. The 5th surgery I would refuse is carotid endarterectomy for asymptomatic carotid stenosis. Carotid endarterectomy involves surgically opening the carotid artery and removing atherosclerotic plaque to prevent stroke. For symptomatic stenosis, meaning stenosis that has already caused a stroke or transient ischemic attack, the surgery significantly reduces stroke risk and is clearly indicated. But asymptomatic stenosis is a different entity entirely. The ACST1 trial showed that surgery for asymptomatic stenosis reduced 5-year stroke risk from approximately 12% to 6%. That sounds meaningful until you examine the numbers more carefully. The absolute risk reduction was about 1% per year, and this trial was conducted before modern medical therapy was optimized. Patients weren't reliably on statins, weren't achieving aggressive blood pressure control, weren't receiving comprehensive lifestyle intervention. Meanwhile, carotid surgery carries immediate procedural risks. The combined stroke and death rate from the procedure itself is approximately 3%. You accept a 3% risk of immediate stroke to reduce a 1% per year risk of stroke over subsequent years. The mathematics only favor surgery under specific circumstances. Here's my protocol for cerebrovascular health. I maintain blood pressure in the optimal range. Hypertension is the single most important modifiable risk factor for stroke. I target blood pressure below 120/80 through sodium restriction, high potassium intake from vegetables and fruits, regular aerobic exercise, and stress management. I take a low-dose statin despite having relatively low LDL cholesterol. Statins have effects beyond lipid lowering. They stabilize plaque, improve blood vessel function, and reduce inflammation. One major trial demonstrated that statin therapy reduced stroke risk by 48% in individuals with elevated inflammation, regardless of baseline cholesterol. I consume foods rich in nitrates that support nitric oxide production. Nitric oxide is essential for blood vessel health. Beets, arugula, and spinach provide dietary nitrates. I eat a large green salad daily. I maintain homocysteine in the low normal range through adequate B vitamin intake. Elevated homocysteine is associated with increased stroke risk. I support heart rhythm stability through magnesium supplementation and inflammatory control. Atrial fibrillation is responsible for approximately 15 to 20% of strokes. My most recent carotid ultrasound showed no significant stenosis and no plaque. These vessels are responding to my protocol by remaining free of disease. Complete protocol and conclusion, 1530 to 1700. Let me share the framework I follow daily. In the morning, I expose myself to bright sunlight within 30 minutes of waking for circadian rhythm optimization. I remain fasted until early afternoon, typically an 18 to 20-hour window. During this time, I take resveratrol and NMN with olive oil for absorption. I exercise most mornings, resistance training 3 days weekly, moderate cardio on other days. My first meal around 1 p.m. is a large salad with leafy greens, vegetables, olive oil, and quality protein. I walk for 15 minutes afterward. My final meal by early evening emphasizes protein and healthy fats. No refined carbohydrates, no seed oils. In the evening, I take magnesium, vitamin D, and K2. I dim lights and avoid screens before bed. Bedroom temperature stays at 65 degrees. Once weekly, I extend my fast to 24 to 36 hours to enhance autophagy, cellular recycling. I incorporate cold exposure several times weekly. The results speak through biomarkers. C-reactive protein at 0.3, fasting glucose at 82, hemoglobin A1C at 4.9%, coronary calcium score of 0, biological age testing 8.4 years younger than my chronological age. These 5 surgeries share a common thread. Each targets a structural abnormality while ignoring the biological processes that created it. Bypass grafts route around plaque but don't stop plaque formation. Fusions eliminate motion but don't address deconditioning. Knee replacements substitute hardware but don't restore the metabolic environment for tissue maintenance. The alternative I propose isn't watchful waiting. It's aggressive biological optimization, treating the body as a dynamic, self-repairing system capable of regeneration when provided the appropriate inputs. Before accepting a surgical recommendation for stable chronic disease, consider whether you've truly exhausted conservative measures. Ask for the evidence from randomized trials. Inquire about complication rates. Request the number needed to treat. The body wants to heal itself. Our task is to create the conditions that permit that healing.